Neil Santos. I'm a instructor in the Vascular Technology program at Oregon Tech, or also known as OIT, along with Leah Jolly, who you heard from yesterday, and Ethan Schlecht, who is going to present tomorrow. So the topic that I'm going to be discussing today is lower extremity venous duplex examinations, and it's kind of a two-part lecture because we're going to focus in, the first part is going to be for patency, so that's going to be for deep vein thrombosis, superficial venous thrombophlebitis exams for patency. And then the second half of the talk is going to be focused on venous insufficiency. So the learning objectives for the patency exam, we're just going to kind of go over a quick anatomy of deep and superficial venous systems. I'm going to discuss testing environments, scanning techniques, and protocol for a successful lower extremity venous duplex exam. I'm going to talk about sonographic appearances in the three modes that we use in terms of B-mode, brightness mode, color Doppler, spectral or PW Doppler. And I'm going to discuss these appearances for both the normal and abnormal situations. I'm going to touch on findings, kind of help technologists with a write-up. I'll give an example of a normal and an abnormal. Doesn't mean that you have to use it verbatim, but it's just kind of a guideline. And I'm also going to discuss briefly about the impressions or conclusions from your reading physicians, because I find it's not only important for the reading physician to understand the technologist's findings, I also find it useful that the technologist understands the impressions from the reading physician. So, duplex evaluation of venous disease. I just wanted to quickly say we are now the gold standard. We've been for a while for evaluating venous disease because we have a high sensitivity rate. So we're able to predict disease at a mid to high 90s%. And we also, for specificity, the ability to test and identify normals were even higher. We like duplex examinations because we're direct testing, we're accurate, we're reproducible, and we're safe. So I'm just going to briefly kind of go into the anatomy. So venous drainage of the leg, we have two main venous systems in the leg. We have the deep venous system and we have the superficial venous system. Deep veins generally accompany with a corresponding artery, where superficial veins do not. They're kind of standing on their own. And both deep and superficial veins have valves that allow blood flow to flow towards the heart. So deep venous system mainly drains blood from the major muscles of the leg. When we get down to below the knee, we usually have a paired venous system called venae comitante. And the venous system actually begins at the deep plantar arch and goes proximally. So just a quick diagram here. Here is the inguinal ligament right here. So when we start our duplex examinations, we are starting just below this inguinal ligament, down the leg, common femoral, and downwards into this is the deep venous system. And over here, if you can see, we have a valve that is closing and opening. So this is just the structure of the bicuspid venous valve. So where do we duplex? Again, start as high up as we can in the common femoral vein, right up in here. And then as we come down, we see the confluence of the femoral vein and the deep femoral vein, also known as the profunda femoral vein. And we work our way down the femoral vein into the popliteal fossa area, where it becomes the popliteal vein. In this popliteal fossa as well, we see the gastrocnemius vein branches that confluence with the popliteal. And then as we go down into the calf, we get into the posterior tibial. It's not labeled, but we have the perineal veins as well. Anterior tibial as well, deep venous system, but we rarely, if any, scan those veins. Other ones that aren't listed here, I talked about the gastrocnemius veins. Usually those gastrocnemius veins that are in the popliteal fossa, they're usually two sets, and they're associated with an artery called the sural artery. And then we have the common perineal trunk, which is right here, and the common tibial trunk is right here. So this is the confluence of the posterior tibial veins joining into a common trunk, and the confluence of the perineal veins that form into the common perineal trunk. Superficial venous system, it drains blood from the skin and subcutaneous tissues. It enters into the deep system, so we go from superficial venous system to deep system. And it also has valves present. So this is kind of an oblique view of the saphenofemoral junction right here. We kind of have the common femoral almost completely transverse, just a little bit oblique. But what's important here is that we see the greater saphenous vein, the great saphenous vein, confluence into the common femoral vein. This SE right here, this is a superficial epigastric branch. This helps drain the abdominal muscle wall. Now, this is a true transverse view of the saphenofemoral junction. Sometimes it's known as the Mickey Mouse sign. So as you can appreciate here, we have the superficial femoral artery. We have the profunda femoral artery. Mickey's head here is the common femoral vein, and the nose is the confluence of the greater saphenous vein that joins in. You don't get this on every patient, but oftentimes you will see this view. So main superficial veins, we have the great saphenous vein and small saphenous vein. Great saphenous vein, sometimes referred to as the greater saphenous or long saphenous vein. It arises and drains blood from the medial side of the dorsal venous arch of the foot. So we're talking medial here. It's running its course right here. The course varies a little bit from a straight pathway. It kind of starts medial, and then it'll run even more medial around the knee, and then it comes a little bit more anterior as we get down into the calf. It connects to the deep venous system at the saphenofemoral junction in the groin. We just talked about the Mickey Mouse. And the greater saphenous vein usually has 10 to 12 valves. It lies, this is a transverse view, so it lies in what's called the fascial envelope or the fascial layer, sometimes known as the saphenous canal. I've even heard it be called, look for the eye of Ra. So if this is the eye of Ra right here, we have the great saphenous vein, and then the eyelids are the fascial layer right here. So the great saphenous vein lies in that fascial layer. Short saphenous vein, it passes up the center of the posterior calf. It's also known as the lesser saphenous vein sometimes. And it empties into the deep system at the sapheno-popliteal junction right here. So that's the confluence of the short saphenous dumping into the popliteal vein. It arises and drains blood from the lateral end of the dorsal venous arch. So we're on the lateral malleolus here. It's on the lateral end, and it runs posterior to the lateral malleolus. Okay, we're going to get into the examination portion. So it's important to understand risk factors for DVT. It helps the technologist with the actual test because a lot of times we're taking a patient history, and with that history, we understand the risk factors. And what we're dealing with is what's called Virchow's triad. So risk factors for any kind of thrombosis is that you can have a hypercoagulable state, patients that are on birth control, hormonal therapy, maybe cancer treatment drugs, they can be hypercoagulable. You can have endothelial injury, which includes surgery, trauma, needle sticks, anything like that, something that injures that vein wall. And then you can have venous stasis. Venous stasis is where blood is not moving. So patients that are immobile, even for short periods of time. We've all heard horror stories of people that have gotten DVTs from plane or car trips or sitting at their desk for too long. So venous stasis right here. Optimum scanner characteristics, we like to use a probe that has a multitude of frequencies, 5 to 10 megahertz. And we like the system to be able to have 3 modes. We have the brightness mode, we have the color Doppler mode, and we have the pulse wave Doppler or spectral mode. B-mode helps differentiate walls of the vein. It also helps determine echogenicity of thrombus if seen. Color Doppler helps with the direction of blood flow. and it helps determine occlusive versus non-occlusive thrombus. Pulse wave evaluates the blood flow that we'll get into. And it's important for the color in a pulse wave Doppler that you set your scale low enough so that you can appreciate venous flow. It flows a lot slower than arterial flow, so you have to set your scale accordingly. Exam techniques, you want the patient to be warm. So a warm patient, a warm room, patient with a warm blanket on, that encourages vasodilation. If we have a cold room, that can cause vasoconstriction. And we want to see these veins nice and full. They're a lot easier to scan that way. What also helps us with that is the patient position. So we want to position our patient with the head elevated above above the patient's feet in a supine position, but it's a reverse Trendelenburg position. So we have the head at certain degrees above the feet. We want to avoid bend in the abdomen or groin to prevent any kind of compression of the IVC or iliac vessels. And we're going to externally rotate the leg. Sometimes it's known as frog leg. So we're going to rotate that leg out. We have to consider that a lot of our patients are older, so we have to understand that it's about their comfort level as well. So here we are, reverse Trendelenburg position. We want this. We want head above feet. Open those veins up. It uses gravity to increase hydrostatic venous pressure to maximize vein capacity. A full vein is easier to identify than someone who is just prone, because if they're just flat and prone, maybe those veins are not to their full capacity and they're harder to view. Here is that external rotation that I was talking about. Frog leg, as it's known as well. We do this position because the veins, they lie medially, and then posterior in the knee. This helps you get into the popliteal fossa and then get medially down the calf. So detection of thrombus, B-mode. How do we use B-mode to determine thrombus? Well, we use it with vein compressibility. Okay, and it also helps locate vein anatomy in transverse. What you want to do in B-mode is you want to do intermittent compressions in a transverse view. And what we do is we apply enough probe pressure to see the walls of the veins coapt together without compressing the artery. It doesn't take much. It's a mild to moderate compression pressure. And we want to see the veins fully open up after the compression is released. The technique, we want to move distally one probe width along the course of the vein and repeat the process. So it's push, probe width, push, probe width. We don't want to skip any kind of segment. So this picture here we are. We're in a transverse view. So we have the artery on top here, vein posterior. And as you can see, the bowing of the skin right here, indentation, we have applied pressure with that probe, and we want to see the vein wall coapt together or touch. Artery obviously has more pressure than the venous system, so that should remain open. If you are compressing the artery, you are pushing too hard. Here's sonographically, we have the common femoral vein, common femoral artery, and you can see with compression that that common femoral vein pretty much disappears. So we know that we have full coaptation for those vein walls. Another example of the femoral vein, again, with compression, we see it pretty much disappear. We know that we have full coaptation. So where do we compress? What's the protocol? Well, again, we start high up in the groin as proximal as we can at that inguinal ligament, and we just start compressing down the common femoral vein down to the femoral vein profunda vein confluence. And then we work our way to compress proximal profunda vein, femoral vein, proximal to distal thigh, and then we get into the popliteal fossa, and we compress proximally to the common tibial and common perineal venous trunks. in that fossa as well. We see the gastrocnemius veins, proximal short saphenous vein as well. And then we get down into the calf, in the medial calf, and we see posterior tibial and peroneal veins. Again, anterior tibial veins rarely assessed, although in my 30-year career, I have seen two anterior tibial vein DVTs. The patient was very specific with their symptoms, and it ran along the shin. So that was a surprise. Superficial venous system, we do the great saphenous vein. Again, we start high from groin, saphenofemoral junction, down to the ankle. Small saphenous vein, that popliteal fossa, that saphenopopliteal junction to distal calf. So we talked about normal B-mode compressions, so full coaptability. Well, when we lose that coaptability and we lost that complete compressibility, then we suspect some kind of material in there, most likely thrombus. It may be partially or fully non-compressible, and echogenicity may or may not be present. It depends on the age that I kind of go into. Again, when we are pushing on these veins, it is very mild to moderate pressure. We don't want to be wrenching on the leg, because if we are in an area of thrombus, we do not want to cause any kind of pulmonary embolism. So the picture here, this grainy dots in here, this represents thrombus. So here we are compressing the tissue, so the indentation of the skin, but we get no coaptability of the vein wall. This picture to the right here, we can see that there's some partial patency of the vein. So this is non-occlusive, and when we compress, it compresses to just a certain level and then stops. Again, we want to make sure that when we are compressing, we're doing this in a transverse view. We do not want to be doing this in a long axis view, because as you can see in this image right here, we have thrombus right here. It is non-occlusive, but we've compressed in a long axis view, and it looks like we have full compressibility of the wall right here, but we have missed the thrombus. So again, transverse view. Detection of thrombus with B-mode. Direct visualization of thrombus, it's the unequivocal determination of the presence of DVT. Color and spectral also help in terms of giving you clues and tools, but this is the unequivocal determination. It helps to differentiate acute and chronic post-thrombotic change as well. B-mode can help you age the clot. Again, this is just partial compressibility. Right here, you can see sonographically that it doesn't compress all the way, but it does some. So now we're going to get into age of clot. Well, we have 3 stages here. I'm going to go over 2, and the next slide shows the one in the middle, because if we note right here, we have acute thrombus, less than 14 days. And then we have what's called chronic post-thrombotic change. This is a new nomenclature, but we in the field, you're going to hear in 99% of the labs, chronic DVT. So this is what they're talking about right here. So acute thrombus, less than 14 days, greater than 28 days for chronic post-thrombotic changes. So the big difference in these sonographically is we have lightly echogenic, hypoechoic, homogeneous thrombus. So low echoes, no echoes sometimes. Another key sonographically, vessel dilatation. So we're dealing, when you have a new acute thrombosis in a vein, it's like an inflammation, and inflammation we know causes swelling. So we actually see the inflammation of the vein by dilating. Chronic post-thrombotic change, the thrombus becomes a little bit more brightly echogenic or hyperechoic, and it starts becoming, instead of one uniform echo throughout the clot, you start seeing different levels of echo within the clot, but not always. Sometimes it can be throughout, but just a brighter, uniform appearance. Chronic post-thrombotic change, the vein can kind of contract. So as it's healing and as it's scarring down, the vein will contract rather than dilate. So that's a good indication of between acute and chronic post-thrombotic change. Sometimes with color, you can see collateral channels. So if we have something that is occluded, the thrombotic process has occluded the vein entirely, you can develop those collateral channels. You can also use color to see what's called recanalization, where the clot is actually kind of honeycombed through. So anticoagulation helps with that. And so you start seeing these little flow channels within the thrombus itself. So 14 days greater than, or less than 14 days, greater than 28 days, well, there's a big piece missing. This nomenclature now has been suggested by the Society of Radiologists and Ultrasound in 2018, called age indeterminate. So it's the age where we're bridging between acute and chronic. And it's formerly known as subacute. This is still used in the field, so you might hear subacute thrombus. So somewhere between acute and chronic, likely over 2 weeks old, but under that 28-day range. May have hypoechoic and hyperechoic components, heterogeneous, a mixed echo. Vessel is of normal size, not dilated per se, but not necessarily contracted either. You have to be aware that whenever we do have a age indeterminate or chronic, even a chronic post-thrombotic change, that you can develop acute DVT on top of that old clot. So how do we determine the age of clot? Well, we just kind of talked about it, but another big clue is talk to your patient. Big clue comes from the patient history. When did these symptoms first occur? If they're saying, hey, it's 5 days ago, and you're seeing the hypoechoic clot, then you can, oh, yep, that's acute. Know the risk factors. When did they have surgery? If we're talking some kind of injury to the vessel wall, when was that injury? When was that long flight or that long car trip or that time when they were just sitting for long periods of time and not moving, and then the symptoms started? So not only can you have the sonographic appearance, but the patient history can also clue you in on aging of that clot. Acute DVT with B-mode, again, low echogenicity. You can see how dark it is in there. You can have hypoechoic, some shadows, or even anechoic where there is no shadow in there. So you definitely have to set your grayscale accordingly. Proximal portion of acute DVT can be non-occlusive and free-floating. But usually as you get past that proximal segment, it usually occludes distally. So you'll see it flapping proximally and then occlude distally. Sorry, this is a quick snippet, and I don't really like this slide because it's backwards to me. So this is the common femoral vein. This should be over here, but you can appreciate that little flapping tail right there, and you can see the low echoes. You do not want to be pushing significantly if you see something like that. Chronic post-thrombotic change with B-mode. So again, we're going to get brighter echogenicity to it. You can see this bright echoes in here in the thrombus. That leads to more of a chronic process. With color, you can also, like what I talked about, you can see evidence of recanalization with color Doppler as well. And as you can see, when we compress, it comes down almost completely, but we can still appreciate those bright echoed, that chronic thrombotic process right here. So here we have a picture, and it's kind of a tweener picture because we're talking about, here we have a floating tail. Well, Neil just said floating tails are acute, but look how bright it is in there. So it's got a lot of echogenicity to it, which leads more to a chronic thrombotic process. So again, patient history can help with this. If there was some kind of trauma, then find out when that trauma was. That can help with aging as well. but then we deem it indeterminate age. Detection on thrombus with color Doppler. Again, we see nothing in here. We have set our scale very low, and we got nothing in here. It's not compressing as well. We got occlusive thrombus. Here in this transverse section, you can appreciate some color on this wall here of the common femoral vein. So we have non-occlusive thrombus. So color is your friend, and it guides you as well. Here I was kind of talking about here, we kind of have a brighter thrombus right here, and we kind of see these little color flow channels through it right here. This could be recanalization, so of a chronic venous process. Like I said, it can kind of honeycomb that clot out, but maybe not completely, but you start getting these little flow channels in there. We're dealing with such low flow states here that we have had to go to power Doppler to pick up this low velocity venous flow states rather than the conventional blue and red color scale. Now we'll get into spectral. Where do we use our spectral Doppler? Well, we use it in the common femoral vein, saphenofemoral junction, profundifemoral vein, popliteal vein. Typically, when we get below the knee, again, these veins, venae commentante, so they run in pairs with an associated artery, and we can appreciate them easier with color Doppler rather than spectral Doppler. Normal venous flow patterns, pulse wave Doppler, spectral. Terms that you're going to hear with venous exams: spontaneous, phasic, and augment. Spontaneous flow occurs spontaneously in a medium and large veins with the patient at rest, even when the extremity is dependent. So it means that we have done no manipulation on the patient, no maneuvers or anything like that, and we're seeing spontaneous venous blood flow. You can appreciate that in the common femoral vein, popliteal sometimes. So as we go distally, we start losing that effect of that spontaneity. Again, flow may be not spontaneous in the small veins such as calf veins. We actually have to manipulate those veins to get flow to happen. Phasic stands for respiratory phasic. You'll hear the term respiratory phasical flow, respiratory phasic flow, meaning the velocity of flow changes in response to respiration. You'll hear it shortened to just phasic. When a patient is during their expiration, that's when we have forward flow to the heart. Inspiration, it kind of shuts down or greatly diminishes. So expiration, we have forward flow to the heart. Augmentable flow means flow that can be augmented, forward to the heart flow with external squeeze, distal to the area of interest. And what we're doing is we're mimicking that calf pump that Leah was talking about yesterday. So we've when we're active and we're moving, that calf pump is constantly engaging, constantly pushing venous blood up the leg. When we're just lying down, not so much, and so we have to augment to mimic that calf pump. So Leah talked about yesterday, antegrade or retrograde. Well, she got into the arterial side, which was antegrade here. We see above baseline flow. We see a little bit below baseline flow, okay? Retrograde. Well, with veins, it's opposite. So we have the foot side and we have the heart side over here. So blood is flowing in this direction in the vein. We represent that with below baseline flow. Arteries one way, veins the other. But this is still antegrade flow because it's going the correct way. When we start seeing flow up here, like with venous reflux exams, this will be retrograde flow. So it's opposite with veins and arteries. Here's an example of spontaneous phasic flow. Here we have the patient who is during expiration here, forward antegrade flow to the heart. And then during inspiration, you can see that it kind of shuts off right here. because the pressure proximally has increased, and we know that we go from high pressure to low pressure, so the abdominal and chest cavity pressure has decreased, and so it allows blood flow to the heart. Here is an example of augmentation. So here we have spontaneous respiratory phasic flow, and here is that calf squeeze that we've augmented that blood flow. Usually when it's sharp, you give a nice sharp squeeze, that you get a nice sharp signal. Abnormal venous flow spectral. When thrombus at any age substantially impedes venous return, you'll see a change in Doppler flow. Proximal to a thrombose segment, flow may be diminished or absent. So this is important. Whenever we're proximal to a thrombose segment, flow may be diminished or absent. When we are distal to a thrombose segment, flow may be what's called continuous. Continuous flow may indicate a more proximal obstruction. Here is respiratory phasical flow, common femoral vein, okay, normal signal. This is continuous flow. We have lost that respiratory phasical component. So with a technologist, if you're scanning the common femoral vein and you see a signal like this, it may indicate a more proximal iliac vein obstruction if it's just on one side versus the other side. If it's on both sides, we may suspect that that thrombus has IVC involvement. Iliac veins and IVC, typically not part of a normal lower extremity venous exam, but again, if we see this signal, then as a technologist, you should be prompted to search more proximally. Another abnormal venous flow is when we have pulsatile flow. When venous flow in the proximal leg veins is pulsatile and not respiratory phasic, it's a good indication that the patient has some kind of either congestive heart failure, tricuspid valve regurgitation, and what it is an increased right atrium pressure that reflects in a pulsatile venous waveform. You really appreciate this when you are scanning in proximally, like in the common femoral vein. Sometimes it can extend all the way down the leg, but a lot of times it's most noticeable in the groin area. So when we have diminished or no response to augmentation, here we tried to augment, well, we're not getting much, are we? And then here we're getting nothing at all with augmentation. So what it does is we suspect some kind of blockage somewhere, but let's say that we get this signal, we've augmented, we get very little or none, but we get complete coaptation of the vein walls. Well, this is a couple slides ago where we talked about, this is where we suspect something that's a little bit more distal. So if you have fully compressible veins, but you aren't getting an adequate response to augmentation, then as a technologist, you suspect something distal to this site. Chronic post-thrombotic change, well, you can have what's called reflux. Reflux can occur with chronic post-thrombotic changes due to the destruction of valve function. So the clot has gotten into this vein and it has destroyed the valve function. Those valves are not able to coapt. The leaflets are not able to coapt together. So here we have augmentation, and then we see this retrograde above baseline flow. This is reflux. We'll get into that more into the second portion of this lecture. Typically, reflux not very noticeable with acute venous thrombosis. It takes time. So if you start seeing reflux, then it suggests more of a chronic thrombotic process. This is just an overview of kind of what I went over. Again, I think I even said that we'll have this lecture available to you. Okay, now we're writing up the findings. Well, the technologist's role is the write-up. It's an important thing to use the worksheet as a guide. The worksheet really helps you out. It can make you less wordy. So worksheet helps used to describe B-mode, color, and spectral findings, oftentimes with a checkbox. Diagram of the lower extremities to highlight thrombus location and extent. Have space for technologist comments. Here is a typical venous duplex exam for patency. You can appreciate here the diagram. The technologist can actually draw in where the thrombus and it is how far approximately it extends. And then the grids right here. This is where we use our findings. We have the sites, and we have if it's phasic at these sites, if these sites have augmented, and if these veins have compressed. So usually a check mark, plus sign means good. Any kind of minus sign or a zero can indicate some kind of disease process. And again, physicians, they like to clue in. They like to clue in the drawing. They like to see if thrombus was seen, yes or no. And then they kind of read the technologist's notes. If you do have to write something a little bit more, how I like to break it down and how I teach my students is break it down per mode, okay? So B mode, this is an example of a normal exam. And again, you don't have to be verbatim for this. But we notice in B mode, we got no intraluminal material noted in that vein, and that the veins fully coapt with compression maneuvers. With color, we see wall-to-wall color filling as long as your scale is set right. So as long as we got complete wall-to-wall color filling, we're good there. Spectral, we note the spontaneous, we note phasic flow, noted proximally, and these veins respond normally to augmentations. I put right lower extremity just as an example. For the impression, the physician's write-up. Again, this is just an example. It can be expanded upon. A lot of physicians like to keep them nice and concise. We put normal right lower extremity venous duplex examination with no evidence of deep vein thrombosis or superficial venous thrombophlebitis. Example for a findings write-up for abnormal exam. What you can say is I see occlusive low echoed intraluminal material with B mode. And again, I'm using right lower extremity as a reference. And we're saying that those echoes are seen in the common femoral vein, popliteal vein, and posterior tibial veins. Veins do not coapt with compression maneuvers. Veins appear dilated in areas described above. When we're talking about these dilated veins, again, we're starting to lean more, is this probably an acute process? Again, low echoed intraluminal material too is another key. Color. Well, in this case, we got no color in the sites noted. And we have no appreciable spectral Doppler flow noted in those sites. So you can see I broke it down to each mode. And example for an abnormal exam for a physician's write-up, you've given them the key, you said low echo, you said dilated, and we said occlusive. So abnormal venous duplex examination of the right lower extremity, acute, occlusive, deep vein thrombosis in the right common femoral, popliteal, and posterior tibial veins. And then they can mention that all other veins in that leg are patent. Okay, so we're halfway there. The next exam that I'm going to talk about is for venous insufficiency. The objectives, we're going to define venous insufficiency, valvular incompetence, and reflux. This term of insufficiency, incompetence, and reflux a lot of times is interchangeable, wrongly interchangeable. So I'm going to kind of help break it down to what each one means. There's a little bit of additional anatomy that we have to focus in on than just the veins that I described before. Quickly, just going to look over risk factors, signs and symptoms of venous insufficiency. How does it present on the patient, on the skin? Again, testing environments, techniques, and protocols, sonographic appearance of B-mode, color, and spectral for normal and abnormal findings. We're going to go into the findings, technologist write-up, and I have a worksheet for this one as well. And then maybe an example of what that write-up for those impressions might sound like. So, insufficiency, the condition of being inadequate for a given purpose. So when it applies to venous insufficiency, it's an impaired or inadequate ability to move blood out of the leg. Incompetence is an inadequate ability of a vein valve to perform the function of one-way flow. So that vein valve is not working and it's allowing two-way flow. Reflux is that backwards flow that's represented either with color or spectral, more often with spectral. So venous insufficiency of the limb, insufficiency usually applies to the limb due to valvular incompetence of the vessel because we've noted reflux of certain sites of that vessel. So we see the reflux, which in turns, we know it's incompetent. In turn, we have venous insufficiency. Again, great saphenous vein. I won't go into detail on this one, but I want you to know that up in this junction right here, we actually have a couple of veins that are important for a venous reflux exam. We have the anterior saphenous vein right here, and then we have the posterior accessory saphenous vein, which rides more medial and up in the proximal thigh area. Going back to the saphenofemoral junction, another representation here is we have greater saphenous vein into the saphenofemoral junction. We have the anterior saphenous vein that rides anterior and lateral in the thigh, and we have the posterior accessory saphenous vein that lies more medial in the thigh there. You can have situations where the greater saphenous vein is competent, but maybe the anterior saphenous vein is incompetent, or maybe the posterior accessory saphenous vein is incompetent. Here sonographically, transverse view. This is the right leg. Both pictures are of the right leg. Here we have the greater saphenous vein running more medial than the anterior saphenous vein. And also here we have greater saphenous vein here, and the posterior accessory saphenous vein running even more medial than the saphenous vein. Anterior saphenous vein, how do we know it's there? Because there's usually what's called an alignment side. Again, right leg, the anterior saphenous vein aligns itself with the superficial femoral artery, just lies above it. So, and we also, I noticed in my career that usually there's a higher incidence of incompetence of the anterior saphenous vein than the posterior accessory saphenous vein, but you do still see posterior accessory saphenous vein reflux. But here's that alignment sign, anterior saphenous vein, superficial femoral artery. Now we're getting behind the knee, we're posterior. This is the short saphenous vein, also known as the lesser saphenous vein. That term still gets used. Here is the sapheno-popliteal junction. Also, this slide shows that you can have vessels coming off, these tributaries coming off these greater saphenous vein, lesser saphenous vein. You can have these tributaries coming off. The sapheno-popliteal junction is an interesting site. This is what we'd love to see for all our patients, is have the short saphenous vein confluence and dive into the popliteal vein right there. You don't always have that case. You don't always have this picture right here. You can have the short saphenous vein actually not connect to the popliteal vein at all. It's called TE, which is thigh extension. So this, a lot of times, this short saphenous vein will continue up posterior thigh and actually join into the femoral vein higher up. So we'd love to see this on all our patients, but we don't always get those views. Vein of Giacomini, it's an important vein because it connects the short saphenous vein. It's a tributary vein that connects to the greater saphenous vein, kind of in the mid to distal medial thigh area. It's also known as the inner saphenous vein. The reason that I'm talking about all these tributaries, and the reason that, or for a technologist to give a clue of what is refluxing and what is working correctly, look at the distribution of the varicosities. If you have varicosities on this anterior lateral thigh, well, we might suspect more anterior saphenous vein incompetence. If we have upper medial, almost groin area varicosities, we might suspect posterior accessory saphenous veins. If we have the more common distribution of medial calf, even medial distal thigh, we can suspect more greater saphenous incompetence. And then posterior, if we have posterior calf, we can suspect short saphenous vein incompetence. And if we have posterior thigh, we can think that there's probably some kind of involvement with the vein of Giacomini. Now, we're getting down into the perforating veins. Perforating veins carry blood from the superficial to the deep venous system. If we're going from we're going superficial through the perforating veins to the deep venous system. If we have flow going from the deep system to the superficial venous system, then we have an incompetent perforator. So again, valves allow blood to flow from superficial to deep, abnormal, deep to superficial. These used to have names associated with them. Now, these perforating veins are described anatomically. So if we're in the proximal mid portion of the thigh, we have femoral perforators. If we're in the distal thigh, we have femoral canal perforators. If we're at the knee level or just below, we have paratibial perforators. And the most common ones that we see are these posterior tibial, formerly known as cocket perforators, down in the calf and above the ankle. Here's a perforating vein, a large one, because a lot of times you don't appreciate them when they're actually normal. But here we have posterior tibial vein, and we have superficial system. So blood flow is actually superficial to deep. Again, superficial to deep, that's the way that you want to see it. I'm not going to go over this too intently. Again, risk factors, I'll let you guys kind of read on those, but there are multiple risk factors for venous insufficiency. One thing I do want to talk about is the venous insufficiency types. You can have congenital. You were born with it. You're born with veins that are missing valves, so or even missing whole veins themselves. So this could be a congenital situation. You see these in children, then you can kind of guess that it's congenital. Primary venous insufficiency is the most common. As we age, that hydrostatic pressure pushes on those vein walls, and those vein valves fail over time because of that hydrostatic pressure. Now, it's genetic, yes. Mom might have had it, dad might have had it, aunt or uncle might have had it, but you're not necessarily born with the abnormality right off the bat, or you don't see the abnormality. It takes time. Secondary venous insufficiency, how I like to think of it, is we have venous insufficiency secondary to some kind of direct damage due to some kind of thrombotic process. So we have venous insufficiency, secondary venous insufficiency due to damage from a thrombotic process. Signs and symptoms. Obviously, varicose veins. I talked about note where the area is, because that's going to help you clue in what major branch is not functioning correctly, which one is incompetent. So varicosities, brawny edema in the gator zone, this inside of the calf and ankle, this medial side right here, actually surrounding it. This is the gator zone. So here we have brawny edema. You can see the discolorization right here. A lot of times this tissue will get indurated, so it hardens up. So that's brawny edema, varicosities. Patients will describe a myriad of symptoms: achiness, heaviness, itchiness, burning, things of that nature. Obviously swelling. Now we've gotten to a more advanced case. We're starting to see non-healing ulcers, ulceration, again, gator zone right in here. Most common site for venous ulceration is at or above the medial malleolus, right here. If you see this in a patient, even before you put the probe on the patient's skin, you should suspect that there's some kind of incompetent perforator either at the wound site or just proximal to the wound site feeding this area. So this is why perforating veins are so important to evaluate as well. Venous insufficiency, it's passive dilation. Vein wall dilates from increased venous in volume. The dilatation actually pulls on the supporting tissue that supports the valve, and then the valve fails and it loses its ability to coapt together. And it's a kind of a, think of it as gates. This gate has failed, and then the next gate has failed, and then the next gate has failed. So it kind of extrapolates on itself. Here's the valve picture we're talking about. Here's normal functioning valves right here. They coapt together, come together. Here's one varicosity where those valves, the dilation has happened. Those leaflets have lost their structure and they are not allowed to coapt together. Gravity pulls, obviously, blood down the leg. Okay, we're getting to the examination here. So we want to see these patients in a dependent position. We want the leg down, okay? So proximal veins, such as common femoral, saphenous femoral junction, proximal femoral vein, you can usually do this, like I said before, a patient lying in a reverse Trendelenburg position, feet lower than the head, but they're still on their back, leg externally rotated. When we start getting to the mid and distal thigh areas, a lot of times technologists will stand the patient and they'll actually have the patient put their weight on the non-scanned leg. So maybe, 80, 90% weight on this leg, 10 to 20% on this leg. Because when we have weight on our legs, we're actually activating a muscle pump there. And so when we have less weight on the leg, those veins are free to open up. It also helps with augmentation maneuvers. If you have a patient with their weight on the leg, augmentation maneuvers oftentimes are not as effective. And the knee and calf veins in a sitting position here. You can have tools. Again, you got a stool right here. They come in different shapes and sizes. These tests are hard on the technologist because we're in weird, uncomfortable places. We're having to get down low on these patients. Standing, we're operating a machine and manipulating veins while they're in a standing position. So you do the best that you can. Save your bodies, guys. So really practice good ergonomics. This just kind of shows the areas what I was talking about for patient positioning. Up here, proximally, reverse Trendelenburg position, you usually get away with. Once you start getting down into the thigh area, standing, majority of with the patient on majority of their weight on the opposite leg. And then when we get down into the knee and calf area, you can have the patient sit as long as that leg is draped over the leg and dependent, so downward. Scanning techniques. So how do we make blood? How do we manipulate blood how we need to? The Valsalva maneuver is one of them. It's a breathing technique that increases pressure in the chest cavity, forcing a reverse pressure on the veins of the lower extremity. We're testing the valves with this. Again, patient reverse Trendelenburg position, spectral. You're going to have your patient take in and hold their breath. And then you're going to have the patient bear down as if they're mimicking a bowel movement or anticipating a strike to the stomach. So if someone was going to hit you in the gut, you would tense up and kind of tighten up there. you're actually doing a Valsalva maneuver. Patient exhales and relaxes. It's most effective for testing reflux in the common femoral, again, proximally, those proximal anterior saphenous branch, proximal femoral vein, and it loses its effectiveness as you go distally. Here we see a normal valve closure. So we have the patient expire or just breathe normal. You have them taking a breath, hold, and bear down, and we see no flow right here. So this is normal valve. You'll see it like a little bit. This is the valve shutting down right here, actually, and the blood kind of stopping. And then when you tell the patient to release, again, you have normal forward flow. Here is an abnormal valve closure. We see reflux, which means that we're incompetent at this site. So we have respiration, they hold, they bear down, and we see this backwards retrograde above baseline flow. This is abnormal. This says incompetence right here. So our job as technologists is to measure the time for this incompetence. This is what the data says. Again, above baseline flow, you got your scale set right. You're measuring the time of that reflux. And I'm going to go into the criteria here in just a second. Another technique we use, distal augmentation. Again, patient standing or they're sitting, so you're in the thigh, calf, knee area. We are actually compress the calf muscle to elicit forward venous flow. Some people can get away with this doing hand compressions. If you have smaller hands or you can't feel like you're getting an adequate response, you can use a cuff that has a rapid deflation capability to it. You're squeezing and you're holding compression pressure for a few seconds above the venous pressure, which is around 70, 80 millimeters of mercury. So you're squeezing, you're holding for a few seconds, and then you're quickly releasing and looking at the blood flow. Where we do this, femoral vein all the way down to the distal calf. So here we have normal valve closure with the distal augmentation maneuver. We have squeezed the leg, and we have little valve closure right here, but again, no appreciable flow above baseline after the release. Whereas this one, we have augmented the calf, and we see reflux, a duration of 5 seconds right here. So this is abnormal. This vein is incompetent because we see the reflux. Just more pictures. Again, augmentation, release, reflux. This one's a short saphenous vein. So again, this down here, color Doppler clues tech to reflux, blue to red. Okay, so this is a perforating vein, kind of what we were looking at earlier, this time with color. This is the superficial venous system. This is the posterior tibial, deep vein. So normally, we have our scale, we have downward flow, superficial to deep. The normal color that we would see is blue. So let's say we've done a distal calf augmentation and release, and we see this just continuation of red. We know it's going deep to superficial. That's an abnormal response. So we have an incompetent perforating vein. So color clues you in to where you should actually spectral. Now the criteria. So abnormal valve closure times, it's not a lot. In the deep venous system, greater than a second means incompetence. In the superficial venous system, just greater than a half second means incompetence. And perforating vein, less than that, 0.35 seconds. You can have a situation where you have a pathologic perforator. These are patients that have had either they're healed or active ulceration. You can determine what's called a pathologic perforator. These have greater than a half second reflux time and greater than 3.5 millimeters. So how is B-mode useful for venous reflux studies? Again, locating and tracking course of the vein. A lot of labs will do a kind of a quick patency check, make sure that we're not getting into any areas of DVT or phlebitis. Again, patient history. Oh yeah, I've had a clot before. Well, you're going to want to check those areas to make sure that there's no active clot in those areas. B-mode is also used for measuring size and depth of veins. This is extremely useful for patients that are going to go on to have any kind of surgical intervention, such as a venous endoablation procedure. It gives the vascular surgeon or whoever's performing the actual surgical intervention, kind of gives them a guide of what these veins are looking like, so size and depth. There isn't a whole lot out there for B-mode in terms of correlating size of vein to incompetence. But there is a study out of South Korea that I saw that a saphenous vein diameter greater than, so 5 millimeters, or a small saphenous vein greater than 3.5 millimeters have a good positive predictive value of reflux, of incompetence. We're measuring in B-mode. Again, this is just an example. We're measuring, so the depth right here to the anterior wall of the vessel. We're measuring that in centimeters. We're measuring the actual anterior to posterior AP view or measurement of the anterior to posterior vein wall. So again, depth measured in centimeters, vein diameter measured in millimeters, anterior to posterior. Color, again, use it as a clue. So we see normally blue, so we got blue downward, that would be forward flow. We have them do some kind of Valsalva, or we augment the vein, and we see red. It clues us in of where we need to explore further with spectral PW Doppler. Again, here's the time. It's all about the time. The write-up, again, worksheet as a guide. It's going to make your life easier. It helps describe B-mode and spectral findings, diameters, depths, reflux times. Give also a diagram to help draw any kind of varicosity bed or tributary like the anterior saphenous vein, and again have space for comments. Here we have the diagram where we have the great saphenous and short saphenous veins right there, because those seem to be the major culprits. But we have room to draw any kind of anterior saphenous vein. Surgeons like this, they like to see the pictures. Here's our grid again of the various sites. We have superficial, we have deep right here, but we can give the physician diameter measurements, depth measurements, and then reflux time, if any, through here. And again, comments. Normal write-up, B-mode, again, the three modes that we use. Veins are patent without evidence of thrombosis. You've done a quick once-over, you don't see any clot anywhere. Normal vein diameter is noted. The greater saphenous, it may jump out of that fascial layer, or some kind of tributary jumps out that you're aware of. That's important, so you can mention that in terms of your B-mode findings. Color, we're a normal exam here, so again, we don't see that extended retrograde color flow. And we have normal venous valve closure times. Again, I just put it as the right lower extremity. And the physician's write-up, concise again, no evidence of deep or superficial venous insufficiency noted in the right lower extremity. Abnormal, if you have to be a little bit more wordy and you're talking about B-mode, maybe you do mention, again, diameters. Hopefully that grid has makes you not have to write this. You can write perforator size as well in B-mode. Color, you're seeing that reversal of when you're manipulating the vein, either with a Valsalva or a distal calf augmentation. You see that abnormal reversal of flow, you can mention that. But the most important one, obviously, again, is the spectral findings, and it has to do with the valve closure times. So if you have to write it out, you don't have the grid for it, then put the seconds on there. Here is the great saphenous vein, right great saphenous vein. I put 4 seconds, so it's above that half-second mark. And posterior tibial perforator, we're at 1 second, which is greater than that 0.35 second mark. Position right up for an abnormal exam might say something like this: venous insufficiency of the right lower extremity with incompetence noted in the superficial venous system. Reflux is noted in the right great saphenous vein from the groin to knee level, as well as in the posterior tibial perforating vein at mid-calf. So we see the reflux, which we know is incompetence for venous insufficiency of the limb. So this is, again, just wanted to tie all those terms together in a impression. References, the big one here, again, Leah said it yesterday, Krupinski, this is kind of like our Bible right here. So great book, get it. I suggest getting it if you're working in the field. And again, a lot of this comes from lectures that we have done. So I want to thank you for your time. I know I was a little long-winded there, but this is a big subject. So again, Tapaho, thank you.
Thank you, Neil. And Lisette, we will stop the recording. Thank you so much.